So I'm Katie Frank. I am an occupational therapist at the Adult Down Syndrome Center in Park Ridge, Illinois, in the United States, and I will talk more about that in a second. I've been an occupational therapist since 2001 and have specialized in Down syndrome since 2006. And I've been at the Adult Down Syndrome Center since 2016 after I graduated with my PhD in disability studies. I am also currently the president of DISMIG USA, which is a nonprofit organization here in the United States for healthcare providers who work with individuals with Down syndrome. So with that, I will share my screen and we can get started. All right. So, as mentioned, today I'm going to be talking about sensory processing strategies to support people with Down syndrome throughout their lifespan. As I mentioned, I work at the Adult Down Syndrome Center. We are a primary care clinic who work with individuals ages 12 and older with Down syndrome. We have 3 family medicine physicians, myself, a social worker, a nursing team, patient advocates, and a project manager who provide direct patient care and a variety of social skills groups throughout the year. Our clinic views health as a 3-legged stool, where in order to have good health, you need to have good physical health, mental health, and social health. And that's how we take the team approach at the Adult Down Syndrome Center. This was mentioned before, but a disclaimer that this information is provided for educational purposes only. Today, we will discuss sensory processing and how it impacts people with Down syndrome. I will share practical sensory activities and suggestions for affordable equipment and provide a few case examples. So first, I'd like to talk about our sensory system. I want you to think about your sensory system being like electrical wiring. And here, the wire is intact and the light remains on. I do want to preface that this next slide has a flashing light, so if that is triggering for anyone, I suggest you look away for about 20 seconds. When there's a kink in the wire, it may cause the lights to flicker. And sometimes we can get this kink in our central nervous system, and it leads to mixed messages in our sensory system. Many times, we may not know what is causing the kink or how to stop our own internal lights from flickering. And when sensory processing is disorderly, the brain cannot do its most important job of organizing sensory messages. All right, that slide is complete for anyone who may have been looking away. So with this kink in our nervous system, we may experience touch, taste, smell, sound, movement, and other sensations differently. Some may feel sensations more intensely, while others feel them less so. And some just do not get the sensory information correct. And this can impact our behavior. So we may see verbal outbursts or aggression towards self or others, destruction of property, defiance, disobedience, noncompliance, tantrums or meltdowns. We might see slowing down or shutting down. And some may think that this person is acting out on purpose or behaving inappropriately when it really could be a dysfunction in their sensory system because the messages are not being sent from the brain to the rest of the body. So similarly, kinks in our electrical wiring could be the cause of symptoms of anxiety, and as a result, self-talk or even compulsive behaviors. We may feel like we have fireworks going off in our body, and we don't know how to stop them, so we act out. This is because the fireworks are keeping the messages from traveling from our brain to the rest of the body. Some anxiety-provoking events that we hear about with many of our patients with Down syndrome could be not tolerating blood draws, or even visits to the dentist, getting their hair or nails cut. Individuals with Down syndrome have trouble with transitions and changes to routine. And it's possible that incorporating sensory input prior to these anxiety-provoking events may improve tolerance. Individuals with Down syndrome also have compulsive tendencies, and sometimes this can slow them down. So sensory strategies may help speed up tasks by limiting the effect a compulsive tendency has on us. So if you think of the compulsion as the kink, and if the kink isn't present, a person can move on without the compulsion holding them back. You can also think about your body or your sensory system as a teeter-totter. So there are times when our sensory system is over-responsive and we are up high on the teeter-totter. And there are other times when we are under-responsive and we are low on the teeter-totter. But when we are regulated, the teeter-totter is even. And our goal is to ensure that the teeter-totter stays even throughout the day. So there are some questions you can ask yourself to determine whether or not it's sensory. And so the first one is, does the person's action disrupt your life? Maybe you have to avoid certain places because of noises or crowds or smells. You can't go out to the restaurant with your family anymore because the person with Down syndrome doesn't like the unexpectedness of if people were to drop their silverware or glass breaks or happy birthday is being sung. So you just avoid it. Or you can't go to, sporting events and gymnasiums because of the whistles or the buzzers or the loudness. So if the answer is yes to this question, if you have to avoid places and it disrupts your life, it's probably sensory and not just a behavior. The next question is, does the action occur with everyone? And if the answer is yes, this is also most likely sensory. If it only occurs with parents or not at school or daycare or with the grandparents, then the action is likely behavioral, right? But if it occurs everywhere or with every person, it's probably sensory. And does the person stop the action when given a reward? If that person is having a meltdown because of a sensory issue, then a sticker or a cookie or time on the iPad is not going to fix the situation, right? So if they stop when given a reward, it's most likely behavioral and not sensory. And so just thinking about if it is truly behavioral, the individual can turn their reactions on and off like a switch, and it's only going to occur with one or two people or in a certain environment. But if it's sensory, it happens everywhere with everyone, and it really disrupts your life. So it is important to know what sensory processing disorder is. It's really an umbrella term to cover a variety of neurological disabilities. And it's a problem with the ability to process information received through the senses. But like I said before, it's important to remember that it impacts the ability for a person to function in their daily life and also impacts you as a family member. The thing is, sensory processing disorder is often not understood. And so an individual may get diagnosed with an eating disorder or anxiety or ADHD or bipolar disorder, or obsessive compulsive disorder, or autism spectrum disorder. And oftentimes, sensory processing disorder is misdiagnosed as one of these and treated with medication or therapies that do not address the underlying sensory issue. However, it is possible that someone with Down syndrome and sensory issues still could be diagnosed with one of these co-occurring conditions. But it's important to know that sensory processing should really be examined Because if medicine or the other therapies aren't working, then it's probably not really, that they have, ADHD, something like that. And actually, many of us have sensory problems occasionally or even regularly, but that doesn't mean that we have sensory processing disorder. Again, it's once this interferes with daily life and becomes a disruption, it could be sensory processing disorder. Now, I'm not really sure about what's happening in the European countries, but here in the United States, doctors aren't actually diagnosing sensory processing disorder, but that doesn't mean it doesn't exist. Unfortunately, and I'll show you in a few slides, occupational therapists are having a hard time using research to show that the strategies we use for sensory processing disorder are effective. So oftentimes the doctors then won't diagnose it, but again, it does not mean that it doesn't exist. And the way I like to describe it to families is that when we have this sensory processing disorder, or just sensory processing issues, really, it's not even being diagnosed with a disorder. It could feel like ants are crawling on our skin or fireworks are going off in our body. For instance, I cannot eat an orange. I don't like the texture in my mouth. And I can leave it in my mouth and chew and try to swallow it, but it really does feel like fireworks are going off throughout my whole body. So I just avoid oranges. But imagine if, your loved one is sensitive to sounds, but you don't know what sounds, and all of a sudden they act out in an environment you weren't expecting, but really it's because they can hear the humming of a fan or the lights, and that's causing those fireworks. Right? And so it's important to really understand the environments and what's going on around us and triggers, because when someone can't communicate what's bothering them, we might see these problematic behaviors, and people will assume it's a behavior again and not a sensory issue. I'm not sure if you're aware, but there are 8 senses. So there are the 5 that are commonly known of touch, sight, smell, sound, and taste. And those are our far sensory systems, but there are also 3 near sensory systems. So our vestibular system, which helps us sit or stand upright, tells us whether we're, laying down or about to fall. There's our proprioceptive system that tells us where our body is in space and how we're able to move our arms and legs and exert just the right pressure on people and objects. And then there's our interoceptive system. And this provides information about sensations coming from within our body. So think about your heart rate, the ability to feel hunger or thirst, the ability to feel the need to use the restroom and digest food. So many of these things that we don't actually control are part of our interoceptive system. And we are going to talk about treatment for these systems later. There are some common sensory deficits in people with Down syndrome. In the tactile system, they may not tolerate certain clothing types, or like lotion on their skin, or brushing their teeth, or perhaps they don't like water on their face. And so it makes a lot of self-care tasks very challenging. With auditory, they may like their music or TV really loud, but they don't tolerate other loud sounds. They may not like when babies cry or dogs bark. They don't like the sound of sirens. And then individuals with Down syndrome tend to have slow auditory processing. So, it takes them longer to understand and process what is said to them. And so that's part of the sensory system. And then also, individuals with Down syndrome tend to have earwax buildup and hearing loss. And so that can muffle sounds, and it impacts how what is heard is processed. With the visual system, individuals with Down syndrome may have poor depth perception, which can make going up and down stairs or over uneven surfaces pretty challenging. As far as the oral sensory system, many might be picky eaters or selective eaters. So they may only eat from certain food groups and avoid complete others. They may only like certain types of food textures, like only soft foods. They don't like chewy or crunchy foods. Sometimes it's even as strict as like they only like certain food colors, so they will only eat beige food. As far as the proprioceptive system, they may stuff food in their mouth, right, and be really fast eaters. And this is because, again, our proprioceptive system kind of tells us where our body is in space. So if they have a choking hazard and you give them small pieces of food, that one small bite of food may not feel like anything in their mouth. And that's why they stuff lots of food and they start looking like a chipmunk, right, with their cheeks out, because that's how they finally feel that food is in their mouth. And they have difficulty regulating their force. So they may do things too hard or too soft. So maybe they don't hold their pencil very tight and it makes handwriting hard, or they pet the dog too hard or hug their, younger sibling too hard. That's a sensory deficit. And then with interoception, many individuals have difficulty feeling thirst, right? So they don't drink enough water. Typically, they don't feel thirsty or they don't feel full. And so they are, constantly asking for seconds. Toilet training may be hard when they're younger, and then individuals with Down syndrome tend to have a high pain tolerance. So this is a little bit of a wrap up on sensory, and it's going to help us bridge to the rest of the topics today. But the common reactions, if it's a sensory issue, is that the person is unable to calm themselves down, even after they get what they want. And their response is going to be the same with everyone and in any environment. I guess it could also be specific environments, right? Because I talked about the restaurant or the gymnasium, and perhaps those behaviors aren't going to happen at home because it's a more predictable environment. And then tricks to help. You want to provide sensory input at regular intervals, which we'll talk about, perhaps a positive timeout in a calm space. And it's important to determine those sensory triggers and to find ways to either avoid them, modify behaviors or environments so that you can deal with them, or just adapt to them. So then the question becomes, who can help? So occupational therapy is a health profession concerned with how people function in their respective roles and how they perform meaningful activities. So your occupation is any activity in which one engages with throughout the day. So I like to say, from the moment you wake up to the moment you go to sleep, I can try to help you with anything you want in order to be more independent. And oftentimes the sensory system may impact that independence. And so an occupational therapist can help with that. And this is because the OT is really going to assess what is interfering with a person's ability to engage in activities. And like I said, it could be an impaired sensory system. Not all OTs are comfortable working with individuals who have sensory dysfunction. And so in OT school, we do learn a little bit about sensory, but oftentimes, unless we're practicing in an environment where we're using the sensory knowledge, we may sort of forget about it. And so we, attend additional continuing education courses to become more comfortable. Many therapists who work in pediatric settings deal with sensory dysfunction a lot. But as a person with Down syndrome ages, and they have sensory issues, there may be fewer therapists who are willing or able to work with them. And again, I'm not really sure about the European countries, but here, many therapists who work with adults may not have experience working with adults with intellectual and developmental disabilities, or they work in rehab settings where there isn't the sensory equipment. So it can be challenging sometimes to find OTs that are comfortable addressing this. And then while there are formal assessments to, diagnose sensory processing deficits, individuals with Down syndrome may not tolerate them. And actually, OTs, it's not within our scope of practice to diagnose. And there are many informal questionnaires that perhaps a parent or caregiver or staff may be asked to complete. But really, a therapist is going to use their clinical judgment and some trial and error to see what works best. I'm not going to go over sensory assessments today because it's possible that there are different assessments that are used in your country. But if anyone has questions about that, I will provide my email address at the end, and you are always welcome to reach out to me if you have questions about specific assessment tools. So what's an OT going to do when it comes to sensory processing? And oftentimes, it's important to seek direct therapy in an outpatient setting. And this is because I know here in the United States, school-based therapists have large caseloads and a short amount of time to work with individuals. And so they may not be able to address the sensory needs in an educational setting. And that may or may not be the case in your country. And also, when we talk about the treatment options using accommodations versus activities, you'll see that in school, it's much easier to provide the accommodations, especially with limited time and resources. So an OT is going to provide a sensory diet, and we're going to talk about that in a second. And oftentimes, it's really trial and error to determine what the best sensory activities are for each person. And this is because, what works for one person is not necessarily going to work for another person. I frequently have families say, oh, my child's best friend uses a weighted blanket. So we bought a weighted blanket and my child hates it. And it could be because the weight's too heavy or the weight's too light, or they just don't like that kind of tactile input or proprioceptive input. And so it really is trial and error. And modifications can be made in a classroom or work or day program, setting as well. So that's the important thing about working with sensory processing. And it really is important to seek treatment because the person really isn't going to outgrow some of these sensory processing deficits. But with treatment, it can positively impact their social skill development and learning and emotional well-being and relationship skill building. So again, like me with oranges, I just avoid them and it makes my life easier. But imagine if all I had, all day long I had to eat oranges, I'm not going to be having my best behaviors all day, and I'm not going to be able to learn because I'm going to be so focused on the fireworks going off in my body from the oranges, and I'm not going to be calm most likely, and no one's going to want to be around me. So that's why it's important to seek treatment. I did mention that there isn't a whole lot of research in sensory processing because it's really difficult to study treatment because it's so highly individualized. However, there has been some published where in acute psychiatric settings, sensory strategies have been effective in creating a nurturing environment and a space for patients to self-organize or self-regulate, right? So that they can make their teeter-totter more even. There was a systematic review that concluded that sensory integrative approach tends to produce positive results compared to having no treatment at all. Children with Down syndrome tend to have low sensory responsivity and sensory seeking behaviors and difficulty filtering auditory stimuli. So low sensory responsivity means that they're exhibiting less of a response to sensory information than the situation demands, or they could take longer to react and may require more sensory input. So when someone's under-responsive, they may not cry when they get hurt, or they may not notice being touched or that they're touching someone else. They prefer sedentary activities. They may not notice that they are dirty. They may not notice that they're hungry or where to use the bathroom, which we mentioned. It could be difficult to engage them in conversations because either the conversation is moving too fast for them, or once they are alert enough to participate, the conversation has already moved on. And then deep pressure is alleged to have a calming and organizing effect on the central nervous system by lowering states of arousal, resulting in positive behavioral and emotional outcomes. And we're going to talk a lot about strategies to provide this deep pressure in a bit. So now let's talk about a sensory diet. What is a sensory diet? It really is a planned and scheduled activity program that is highly individualized. And activities are provided at regular intervals, maybe every 1.5 to 2 hours. And when incorporating a sensory diet, you can do it before an activity and it can really help that person move through the transition or prepare for a change in routine more easily. But it really can also be used as a recovery technique if that person does become overwhelmed and acts out. And I said before, a sensory diet can be implemented at home and in the community because it's really designed to provide that right combination of sensory input to keep that optimal level of arousal or performance, or to keep that teeter-totter even. And I like to tell families that it should be more like choosing from a menu rather than following a recipe. So, trying to keep like a toolbox of sensory strategies. So in your toolbox, you may have a variety of sizes of both flathead and Phillips screwdrivers. And that's kind of what you need for your sensory toolkit. Perhaps today that person really is going to like, the joint compression that we'll talk about, but tomorrow it may not work, or later in the day, and then they're going to want to do push-ups or to go for a walk, right? And so having a variety of strategies that the person enjoys so that you can kind of try it. Oh, they don't like it today. Let's try something different and take a new tool out of the toolbox. And like I said, sensory diets really are individualized. And when I say they may not necessarily always be convenient, this is because you may have to bring some strategies with you when you leave the home in case the person tends to have a meltdown in an environment that is new, right? And so that's why it wouldn't be convenient. But overall, it's going to help with their emotional well-being, and it's going to help them be able to tolerate more activities and environments. And so then they can be more active participants in their occupational performance. And this is something that's really important to me, is that sensory input should never be given as a reward or removed as punishment. And we see this oftentimes with behavior plans in the school systems here in the United States, that because, maybe time on the swing, they see that as a reward. So if the person keeps acting good and, they're having good behaviors, then they get rewarded with the swing. But the thing is if their behaviors are really sensory reasons, that person needs the swing no matter what. And so it should not be removed as a punishment. And there are different types of activities in a sensory diet. They can be alerting, they can be calming, they can be organizing. But again, we want to keep that teeter-totter even and that optimal level of arousal or performance. And so the alerting activities are going to benefit that person that's under responsive, that person that needs a boost. So maybe it's eating crunchy foods or taking a shower, maybe bouncing on a trampoline or sitting and bouncing on a therapy ball, maybe swinging in a circle or swinging very fast. Those are alerting activities. Then there's organizing activities. And this is going to help regulate the person's responses so they can be more attentive. So maybe eating chewy foods or doing heavy work activities, which we'll talk about, or maybe offering vibration. And then there's calming activities. So these are activities that help decrease the sensory over-responsiveness that someone has, right? And so maybe it's sucking on hard candy, or again, doing that heavy work. It could be swinging back and forth or forward, maybe rocking in a rocking chair, getting deep pressure or a massage or joint compression, which we're going to talk about. Weighted vests and blankets can be calming, perhaps playing with a fidget or having a sound machine on. And again, the thing is this all is highly individualized. And honestly, what might be calming for one person could be alerting for another. And it's important to know that you can be under-responsive in one sensory area and over-responsive in another. And so again, that's why it is beneficial to have an occupational therapist help with that. So remember earlier when I mentioned the far versus the near sensory systems? Now let's really talk about the treatment for that. So those near systems require activities, and this often involves therapy in order to treat them, whereas the far sensory systems can be addressed by providing accommodations. So for instance, if a person has deficits with their proprioceptive system, we may want to incorporate heavy work activities and encourage them to use their muscles and their joints to increase their body awareness. But that same person may not like gymnasiums during basketball games because of the loud sounds, whether it's the whistle, the buzzer, the fans. And so we can make an accommodation by encouraging them to use sound reducing headphones. So again, it's sensory accommodations for those far senses, which involve sight and sound and touch and taste and smell, and the activities for the near senses for proprioception and vestibular. And we often need to address those near sensory systems before we can address and make an impact on those far sensory systems. And so again, this is why therapy in school is challenging here in the United States, because again, the therapist may not have enough time, or just even throughout the day, the teachers, to provide these sensory activities, but the sensory accommodations are much easier. So that's why it's recommended to have direct outpatient therapy. But again, it could be very different in your countries. So here are some sensory accommodation examples. Perhaps for vision, you might have them wear sunglasses if the bright lights outside are too much, or they might need dim lighting in their classroom, or they might need a study corrals or sit in the very front of the classroom or close to a wall, just so they're not easily distracted by the things going on around them. For sounds, they may wear headphones. Perhaps they wear sound reducing headphones if it's too loud, or they can wear headphones with their own music if they need something that could be calming for them. For touch, maybe they don't like when their hands get dirty, so they might need to wear gloves, or they don't like the feeling of the seams in their socks or the labels in their clothing, and so you remove them. They may need to seek out touch, and so you would give them some kind of fidget to play with to help them with attention. If it's something with the oral system, maybe they need bland foods for flavor versus spicy foods. Or maybe they need those soft or pureed foods instead of crunchy foods, or vice versa. And if they're sensitive to smells, maybe you have air purifiers to try to limit the smells, or you limit the perfume or lotion scents. But some may really seek out scents, and so you might have air fresheners or aromatherapy. And then for the sensory activity examples, I'm really going to focus on proprioceptive input today. And again, this is that input into the muscles and joints. And it's really one of the first strategies I use here at the Adult Down Syndrome Center. And that's because individuals with Down syndrome tend to have low muscle tone, which can impact how they interpret the sensory input coming in through their muscles and joints, and why that proprioceptive input may be so effective, but also why they may need more of it. And as the research told us, that this is important because the deep pressure input is supposed to have a calming and organizing effect on our central nervous system by lowering our states of arousal, which can help result in positive behavioral and emotional outcomes. And so we find that individuals actually may present with the behavior change when their natural opportunities for proprioceptive input have changed. So maybe when COVID first started, when programs were canceled and schools were shut down, they had less physical activity. When individuals graduate from school and don't have programs to go to, or over summer breaks, right, we may see an increase in behaviors because there's a decrease in physical activity. And so some proprioceptive input strategies can be alerting or organizing or calming, and it really depends on the person's needs. So one great thing is just everyday activities like chores, because you're using your muscles and joints when you vacuum, or if you're carrying or sorting laundry, if you're wiping down counters or cleaning windows, right? Natural opportunity for proprioceptive input. Also, exercise can naturally provide that proprioceptive input. They talk about having, the endorphins in your body when you exercise, but it's also possible that your body is regulated, and so that teeter-totter is even, and that's why you feel so good after exercise. Joint compression is a type of proprioceptive input, and it's like a mini massage, and I'll show you an example in a second. But what's great about this is that no equipment is needed, and you just need your two hands. And if that person really likes joint compression, then they can perform push-ups independently, either on the wall, against a table, on the floor. And then they don't need anyone else present in order to get that proprioceptive input. We also trial weighted objects. So whether it's a weighted snake or a weighted lap pad or blanket for effectiveness, physical activities like riding a bike, playing sports, and walking are really great ways to get proprioceptive input. And then vibration can be an effective strategy to provide proprioceptive input as well. So in our resource library, which I will share the website with you at the end if you aren't already familiar with it, we have a handout on what proprioceptive input is and how to incorporate it throughout the day with a variety of activities. And again, this kind of covers the lifespan, so not all might be age appropriate. We also have a resource on joint compression. This one is for the upper body. So you can see via pictures and the description on how to complete joint compression. You don't usually need to do joint compression to the lower body just because we naturally get that input through walking. And then sensory equipment can be really expensive if you try to purchase it through websites. So here are some alternatives, ways to get sensory input and places to find some of the equipment in more affordable ways. And again, you're not going to have all of these stores available to you, but you can see pictures of different things, equipment that I recommend. But it is really important to note something here about weighted products, especially weighted blankets. First off, it is recommended that weighted products like a blanket be 7 to 10% of a person's body weight and not more. However, it really can be less if that works best. And so here in the United States, at least, many of the commercial weighted blankets advertise weights that are more than the recommended 7 to 10%. You can see here in this example, the weight ranges from 14 to 26% of someone's body weight. So please do not refer to their weight suggestions when choosing to purchase a weighted blanket. It is also highly recommended not to sleep under a weighted blanket, even though I know that that's how they are advertised. And this is because if there are concerns with seizures or asthma or sleep apnea or cardiac issues, it really could impact them. However, a weighted blanket really could be used as part of a bedtime routine in order to calm before falling asleep. And it's really best to use weighted products with supervision to ensure safety. And then the other thing is we really don't need sensory input for more than like 20 minutes at a time, and even less is fine too. So that joint compression may only take 45 seconds and you don't need to do anything else for another hour and a half. But if you wear glasses, maybe for reading, and then sometimes put them on your head or your sunglasses on your head, after a while, you're like, oh my gosh, where did those go? And it's because your body has tuned out that the glasses are on your head because it's not causing pain, right? And so when we realize that something's not harmful to us, our body forgets about it. And it's the same with sensory input. So that's why another reason it's not really effective to sleep under a weighted blanket or to wear a weighted vest all day long, because it eventually loses its effectiveness. So I have time for some quick examples just so you can see how I use sensory strategies throughout the day here at the clinic. So perhaps it's a 24-year-old with fear of blood draws. We talked about how sensory strategies can be used to help with anxiety. And so with someone, we may want to use proprioceptive input prior to the activity in order to calm and relax. So whether it's joint compression, a big bear hug, using the weighted blanket during the blood draw, all of that could help. And so those are sensory activities. We can also try desensitization strategies to help build and develop tolerance to blood draws, but that's really different than just providing sensory activities, right? But the sensory activities might help prepare the body better, right? Might make the teeter-totter a little bit more even, stop the lights from flickering, so our body is open to those desensitization strategies. And visual supports can be really helpful, whether it's a story talking about what's going to happen during the blood draw, whether it's a first we're going to get the blood draw, then we're going to go and get a burger at your favorite restaurant or whatever it might be. But these sensory strategies, that proprioceptive input to calm the body, can make someone more open to these anxiety-provoking events. What about the 8-year-old who gets stuck organizing the stuffed animals on her bed, and this impacts her ability to leave for school in the morning? So that, they all have to be in the exact same spot or this exact right spot, and one falls over. So then she has to start all over again, and then she's late for school. So again, this proprioceptive input could help to reset her body so she does not get stuck. So maybe when she wakes up in the morning, she does 10 wall push-ups, right? And takes a shower. And then her body might feel regulated enough that even if one is out of place, she can move on. You might also have to use visual schedules, reminding her that she's going to wake up, do those wall push-ups, take a shower, get dressed, make her bed, and go eat breakfast. So she knows as soon as she makes her bed, she has to go down and eat breakfast. Or you show how many stuffed animals she can have on her bed. There's only 4 allowed, and then we leave for school, whatever it might be. But again, starting the day with proprioceptive input could help her get through the rest of her morning routine. What about the 56-year-old that has Alzheimer's disease and displays periods of agitation, especially around dinner time, and the family can no longer go out to eat at a restaurant or even to family gatherings? So instead of necessarily providing those sensory activities, this is when you would want to provide those sensory accommodations. Because since dementia impacts the brain, it can really impact how someone perceives the sensory input. So maybe we make sure to have all of the lights on or dim the lights depending. Maybe there's calming music in the background during meal times. If there's a mirror in the dining room or wherever you eat, cover the mirror, because they may look at themselves and not realize it's them and think that a stranger or someone is staring at them. Maybe you consider having calming scents like lavender, or if you're going to be at a family gathering, making sure you have all of their favorite foods. So here are some key points to remember about today's talk. Sensory processing differences does not mean that the person is on the autism spectrum. Proprioceptive input will help everyone, so encourage physical activities throughout the day. Consider proprioceptive input when an activity or procedure may cause anxiety. And when in doubt, talk to an occupational therapist. As I mentioned, we have a resource library at the Adult Down Syndrome Center that is available free of charge. It has articles written by the team at the Adult Down Syndrome Center, as well as links to helpful resources from other organizations that support people with Down syndrome. You should have access to this PDF, so you would be able to click on that link to open the entire resource library or all resources, and then the link specifically just for sensory resources. There is a search bar at the top where you can type in a term, and then all the resources will come up. We also have resources specifically for people with Down syndrome, specifically for families or caregivers, and specifically for healthcare professionals. So you can sort by the audience or just by the topic, and then all will come up. We also have a Facebook post, so you're welcome to follow us on Facebook. We share one post a day that highlights resources in our library and shares information about upcoming events. If you're interested, you can sign up for our email list. We have 1 to 2 emails a month where we just kind of talk about the things that are going on in the center and highlight any of our new resources. These are just some of the articles that I referenced today in case you have any interest. But here's my contact information. You are welcome to email me with any questions that come up, especially if we don't have time to answer them all today. So with that being said, I am happy to start taking questions.
Thanks a lot, Dr. Katie. Yeah, it was very nice and very interesting. I'm sorry because I had problems on the beginning. I hope now it's everything okay.
Yes, I can hear you just
You
fine.
can hear me. Yes, thank you very much. Yeah, we had several questions, and maybe we could start. You see as well the questions and answers part.
Yes.
Yeah, and we see that we have a several question from one person, and I could suggest that we start first with a question from Elizabeth Turning, and then we will come on the back on the end with Kerry Rogers, if it's okay. Could we start first with Elizabeth?
Yes.
Yeah.
So the question is, you work with Down syndrome, but don't you think that sensory disorders or treatment will be the same for most persons with intellectual disability? Absolutely. Yes. So, like I said, anyone could have sensory processing deficits, but any of these strategies work with neurotypical people as well as people with any kind of intellectual or developmental disability. Absolutely.
Yeah. Okay. Thank you very much. Okay. Maybe we go to the next question from the Rima Krivoshe. I will translate to you. That is how to react in a case of the masturbation of the person with Down syndrome.
Oh gosh, sorry. Can you say that one more time?
How to react to masturbation.
So I would say that that's not necessarily a sensory issue, although it could be. A lot of the puberty things and dating relationships are another thing I address a lot at the Down syndrome clinic. So just because there are probably other questions, can I save this to the end to make sure we have time, since that is not
Yes.
necessarily on topic with sensory?
Yes. Okay.
But I'll
next
be happy to come back and answer it.
Yeah. Next one is from Sarah Ernie. If you could read her question.
Sure.
What is the difference between person with Down syndrome with autism?
What is the difference between a person with Down syndrome with autism who has got also sensory processing deficits part of the autism, and a person who has Down syndrome and who has only had sensory processing deficits, no autism? How do you exclude autism? So typically, in order to diagnose autism, you're going to work with a team who looks at all facets of the individual with Down syndrome. And so there is some criteria to differentiate a person with Down syndrome that has sensory processing with someone who has the dual diagnosis of Down syndrome and autism. And so one of the main things is that individuals with Down syndrome and autism do not have the high social skills that someone with just Down syndrome may have. So they're going to appear more like that person with autism, with little eye contact. They may be nonverbal. They may not have intentional communication. So even if they are nonverbal, they don't try to communicate their wants or needs, even by like gesturing or grabbing things or pointing. And so just like the rest of us, some of us can still have sensory processing deficits and not have autism even without the Down syndrome. So it really does require a team. It's very hard to diagnose. The person really needs to know Down syndrome because there are so many things that overlap, honestly, between Down syndrome and autism, and things that can just be the Down syndrome. And so sensory processing is not one of the criteria really to say, oh, this person has autism. It's just one piece of it. But really, in the dual diagnosis, it's the communication piece is one of the primary things.
Okay, thank you very much. Maybe we could go to the question from Katie Service. Can you please address the overlay of dementia process upon people with lifelong sensory processing issues?
Yes, and then it says, I suspect having a baseline of sensory processing life story would be beneficial. Can you suggest any tools families and others can use to gather this baseline? Hi, Kathy. I am not 100% certain what you are asking as far as this, but Yes, so sensory processing is lifelong. I think it's important to understand though that sensory processing can change as we get older. And so sometimes things can get worse, sometimes things can get better, sometimes we have new sensory things. So oftentimes, as someone with dementia, they may develop sensory deficits that they didn't have before. And this is just because the brain now is having an even harder time interpreting what sensory information is coming into the body. And so while having a baseline of understanding of what they were like, I don't know if that's going to impact them as much once they have dementia, because so much can change. So I think, again, having this baseline would be hard, but there are assessment tools I use here in the United States that could be of help to you, Kathy, and I would suggest you reach out to me and I can tell you some of the tools that I use here that families and caregivers can complete. But a lot of it is really just self-questionnaires.
Yes, thank you very much. Should we go to the just one question or one ask for you, Kathy? Please, could you come back to the references in your presentation? Because some of, yes, thank you very much. Okay, let's go to the next one from Jenny Tamisto. Hi, what do you do when the job place does not care for this, what talk today? Do you read it?
Yep. So it says, what do you do when the day or job place does not care of this? I'm guessing of like sensory processing, and they don't want to use these tips for the person with Down syndrome. Well, I feel like many of these strategies are helpful for lots of people. And I think for those of us even that work, we do sensory strategies throughout the day in order to keep our body regulated so we can attend, especially when, if we get tired, we might get up and go for a walk. We might try to drink some water or coffee, right? And so that person with Down syndrome should be able to access all of those same opportunities. I find it that oftentimes individuals with all intellectual and developmental disabilities, especially in the workplace or in school, are under a microscope. And so they can't do anything without someone watching them. And so it shouldn't be a problem to build in these mini breaks that the person needs in order to be successful. And depending on the job, these strategies can easily be built in. So for instance, if the person works at a grocery store, perhaps they are bringing in the carts or stocking shelves, and that's naturally providing proprioceptive input. So trying to find tasks at the job place that they can do that are going to naturally provide that sensory input if they can't build in the breaks.
Thank you. Maybe now we could go with the several questions from Kerry Rogers.
Okay.
We could start from the beginning. Have you seen a sudden onset on new insist on wearing or at least carrying the same clothing like pajamas all the time?
Yes.
Then we have about
I'll start there.
Yeah.
Yep. And I'll move down. Wonderful. Thank you so much. So yes. There are instances where people go and they want to wear the same clothing every day. And it could be just because that's comfortable for them. It also could just be part of their routine or their groove. And so we often suggest families have multiple pairs of those same pants or multiples of those t-shirts so they at least can wear clean clothes every day. But this is a time where you can try to stress the importance of wearing other clothes. So maybe we wear this outfit on Mondays, Wednesdays, and Fridays, but you have to wear something new on Tuesday, Thursday, something like that. But yes, we see that frequently. And so I would say it's a combination of sensory and behavior. And so visual supports could also help with that. The next question is, how can we redirect teeth grinding? So again, that's going to be proprioceptive input. So you want to look at what kind of diet the person is on. Perhaps they don't eat enough chewy or crunchy foods, so they're not naturally getting that input into their mouth. And so you would want to try to incorporate that. Maybe also drinking from a straw. You can also do some massage to their jaw, and that can help. I know some people like to do chew tubes and jewelry and things like that, but that's not always functional for someone as they get older. Also, can we reteach eating so that an individual with Down syndrome and severe ID is not stuffing food in mouth to the point of choking? Yes, so you can do that by limiting the amount of food on their plate at a time. I'm also wondering about their chewing. Perhaps if they're not good at chewing anyway, then you're going to want to work on that as well, because it depends. It might not be how much food they're stuffing in their mouth, but their ability to, like, they're only chewing once or twice and trying to swallow. But yes, that is something that can be taught, and an OT or even a speech therapist can work on that. How do we help individuals? Sorry, do you want me to keep going with Kerry's questions?
Yes.
Okay.
But I'm just cleaning, all questions that just come from Kerry,
Okay.
because some of them you already answered, but okay, so just you comments.
Okay. How can we help families with adults with Down syndrome, severe AD, with no functional communication who are living in the family home? Well, I feel like everyone can have some form of functional communication. We just have to figure out what that is. Pictures are a great way. It doesn't have to be a communication device like a talker. I mean, there's apps on phones. We can make pictures, pointing to things, offering choices, and having them select one if you just offer two choices. So there's definitely ways to make communication functional, even if someone is nonverbal. How would you work with sensory diets for individuals with Down syndrome regression disorder and catatonia who show no desire to engage in anything with anyone? That's a wonderful question. So I think these are things that you can, there's things you can try to give them. They may not give you the feedback that they're enjoying it, but they might also, that you might put a weighted blanket on them and then they push it off. The other thing, though, is that we have to make sure when giving sensory input, we have to rule out all these other medical causes. And so perhaps it's something that we really need to work on, this Down syndrome regression disorder, and what kind of treatment is effective, perhaps, so that they can then tolerate the sensory diet. But again, it's going to be trying to do things to them until they're at the point where they are willing to engage with others. What would be an activity to help with proprioceptive input for overstuffing mouth when eating? And I feel like I started to talk about that. Again, you want to provide other sensory input that is going to help. So perhaps it's doing the oral massage beforehand or doing vibration in the mouth. So you're going to alert the mouth and wake it up. So alerting strategies to the mouth could then help, because then they're going to have more feeling in their mouth with the smaller foods and not overstuff.
Yes, thanks. We did about Kerry. I think we finished. Now Camilla said, okay, thanks to you. And also she has a question. Do they sensory processing deficit change over time? Do you get worse with age? Oh.
Yep. Or can they get better, or can one affect the process? Absolutely. So they do change over time. Now, I can tell you, I haven't had an orange in probably 25 years. I have no idea what would happen today if I tried one, and I'm not going to try. But yeah, so they can, like, they just modify, right? So we hear like, oh, they used to have a really hard time with certain clothing, but now they're okay. Because sometimes it's just something you're sort of desensitizing to them if you're having them try stuff, or they found a way to regulate their body where these things that were bothering them at one point don't bother them anymore. So that and so, and things could get worse, but they definitely can get better, but they can change, right? So they were very sensitive to tactile when they were younger, but now it's more auditory.
Yep, thank you. Okay, maybe we could go to a question from Auburn. Yes, it's a question. What is the difference between scope of the practice of these two occupations, speech therapist and language therapist?
Yep. So I think, is it just in regarding to feeding disorders and Alzheimer's? I think it really depends. So some speech therapists are going to only focus on communication and language, and others may also work on feeding. Just like with occupational therapy, someone may focus on self-care skills, someone may work on sensory, someone could work on the school skills. I think it varies. In many settings, a speech and language therapist could also work on feeding, just like an OT. When it comes to speech, might look at the oral motor skills, the ability to chew, what those muscles are doing, whereas an OT might work on the actual ability of self-feeding, so bringing the food up to the mouth, and then the sensory component of being a picky eater. But speech therapists also can work on picky eating. So I think oftentimes they overlap. And in many feeding clinics, you're going to have a speech therapist and an occupational therapist working on it. And then so with Alzheimer's, oftentimes we're going to see someone who may be having incidences of choking. So then we have to work on that. So that might be more speech therapist than an occupational therapist. But if it's about self-feeding or food or how the food is served to them. So someone with Alzheimer's ends up kind of having the scope of their vision almost is like macular degeneration. Their world just gets smaller. And so then you have this plate, and maybe the plate is white, and you have mashed potatoes and bananas and something else because they need a soft diet on this plate. Well, the food is blending into the plate. And so then they may not be feeding themselves because of that, because they can't differentiate where the food is and where the plate is. And so that would be something an OT would work on instead of a speech therapist.
Yeah. Thank you very much. Okay, we have one question in Croatian. I will try to translate, or maybe our translator Zana could help us. But I could translate. We have now several questions, but I could see what is specific per child and the family. And just I would like maybe that we have a question like Brahmos for everybody. Did you had some situation that some person with Down syndrome, especially a small child, had a problem to drink water or juice? They didn't like it, juice or water, but they like it some kind of the special type of the milks. Did you have that in your work with a person with Down syndrome?
Well, so I think individuals can definitely have different preferences for whether it's food or different liquids. I don't know if it was a consistency, because maybe milk is a little thicker than a juice or water, or if it was the taste. So OTs could work on that to try to find ways to present different liquids. Oh gosh, I was just thinking of something else I wanted to share with that. It could be how the liquid is presented. So maybe they have trouble with drinking from an open cup or a sippy cup or a straw. And so trying different types of cups to see if that liquid is presented in that way, if they tolerate it better.
Yeah, okay. Thank you very much. I don't know, maybe Fulya, you could help us with this Turkish, but I have a translation for French. That's this question from Jean-Louis Fer. It's what can be done for a person with Down syndrome who needs to use ointment for their skin problems, but doesn't want to touch their skin? I hope, Katie, I helped.
Yeah. No, I understood that completely. So yes, so many individuals with Down syndrome, because of their dry skin or the boils they get, need to put medicine, ointments, lotion on their skin, and they hate everything about it. So there are alternatives, I guess. We do have a resource where you could do like a spray lotion, and maybe they would tolerate that better on their wet skin. And, or there's different, just the consistency. Or again, you could use it as a reward system that, you have to put this on and then you get this, like a first then, or if they tolerate it, they earn something. Because again, that impacts their health. And so we have to find ways to provide accommodations. Maybe you have them in control of putting it on, so they feel like they're in charge, but they wear a glove to do it. So they don't have to touch it, but then it touches their skin. Or we provide, maybe vibration around the area where you have to put the ointment, because then it's kind of alerting the skin a little bit that it like activates it so much that they're not going to notice that the skin's on there, because the vibration felt so good and kind of alerted their sensory system in a positive way instead of a negative way. And so then that ointment isn't going to impact them and have this negative feedback where they feel like those fireworks are going off.
Yes, thank you very much. Okay, I would like to say that maybe we take just one more question. Now it's 6 o'clock in the evening and 40 minutes. Okay, there are some, like I said, questions about specific, some things for the children, because the oral problems, because of the some tactile problems, and if we are going very deeply in this whole question, I think it's really much more personal things that maybe could they ask you on this mail what you gave to them. Fulia, please, could you maybe say your questions that is not possible here? Fulia? Okay, Fulia is not answering. Okay, in that case, I would like really to thanks to Dr. Katie Frank for this very nice webinar what we had today. I would like to inform all who ask us, this webinar is available on the Facebook site of European Down Syndrome Association, ETSA, because this live webinar was there, and you could go and watch again and listen again all what Dr. Katie Frank said. Also, we will have in about 1 week or 10 days, we'll have on our YouTube channel a combination of all our translation. That means we have in English, but like I said on the beginning, we have in several languages, and we recorded that and we will put on the ETSA YouTube channel, and you could check and listen again. And normally on this YouTube channel, you have all our previous webinars, and you could watch. And if you have some question, you could come back to our email address, what we showed also in the beginning. I would like to finalize this our webinars with big thank to the Katie Frank, and she was very responsive immediately when we asked her to give us this very important presentation for our not just young person with Down syndrome, but also with the youngest and also with the older person, how to do some things, how to react, and you help us so much. I would like really to thanks to all of you who attend today webinar, and we are looking forward to see you next month as well. We will inform you when it will be, but usually like we have it is third Wednesday in the month, and let's see very soon. And once again, I would like to apologize for the beginning and problem what I had a technical, they always said the people who are involved in something, they have a problem, like I'm involved in informatics, but always had some problem with technical things. Thanks a lot, Dr. Katie Frank, and have a nice day. And to all of you, a nice afternoon and a nice night, and see you soon.